Observe a physical therapist during a complex manual adjustment. Delivering effective care requires heavy physical tension, intense focus, and precise mechanical leverage. Our previous analysis of strategic intent established that a hospital's mission relies on its operational capabilities. At the clinical level, those capabilities rest on the physical and mental state of the therapist. This creates a specific professional paradox. Physiotherapists must maintain peak condition to treat patients who have lost theirs. Sustaining that peak is difficult in modern healthcare. APA data shows 64% of respondents report work as a significant stressor. NIOSH data adds 40% find their jobs extremely stressful, and 27% are so stressed they struggle to function. These numbers show that chronic, unmanaged stress actively degrades a clinician's capability to deliver care, transforming a personal burden into a systemic operational risk. To solve this, we must use the clinical definition of job stress, the harmful physical and emotional response that occurs when job demands do not match the worker's capabilities, resources, or needs. Acute stress is a normal evolutionary survival mechanism. Driven by the sympathetic nervous system, it provides short-term motivation and helps humans evade immediate danger. However, the modern clinical environment lacks clear start and stop signals. The brain remains locked in high alert. When clinical demands continually stack up through heavy patient loads and complex documentation, without an increase in recovery time, the scale breaks. This sustained mismatch forces a transition. Psychological burdens mutate into physical pathology, manifesting as burnout that persists even after the clinician leaves the hospital. Treating this mismatch as a simple test of willpower results in operational failure. Capabilities must be actively managed to meet the environment's demands. This operational failure translates directly into human physiology. During a shift, clinicians often ignore the immediate autonomic warning signs of stress, heart rate spikes, and elevated blood pressure. These cardiovascular changes are accompanied by secondary acute signs: flushed skin, a temporary loss of blunt pain response, dilated pupils, and rapid breathing as the body prepares for a physical threat. When the nervous system stays locked in this state, the pathology becomes chronic. Sustained muscle tension from constantly being on edge leads directly to musculoskeletal disorders in the therapist. The degradation continues through systemic failures, including long-term cardiovascular disease, gastrointestinal symptoms, and impaired immune function. This physical breakdown carries a high cost. Healthcare expenses are nearly 50% greater for workers who report high levels of stress compared to those who do not. By failing to manage their autonomic responses, physiotherapists suffer structural degradation to the exact physical systems they are trained to heal in others. To address the internal biological response, we must audit the external operational triggers. A clinician's physical environment and organizational structure dictate their stress levels. The first audit category is the design of tasks. Heavy patient workloads, the absence of scheduled breaks, and back-to-back appointments act as primary stressors on the treatment floor. Second, we audit management style and work rules. Poor communication, unclear role expectations, and a lack of growth opportunities act as compounding threats to stability. Finally, we must assess the environmental conditions of the clinic. Realities like constant noise, poor clinical ergonomics, or hazardous conditions act as a direct drain on a therapist's physical capabilities. This mapping identifies clinical burnout as an objective failure in operational design, rather than a simple lack of individual willpower. The APA outlines 10 evidence-based strategies to manage job stress. Each serves as a targeted strategic intervention to rebuild clinical capability. Group 1 focuses on physiological interventions. The goal is to deliberately downregulate the autonomic nervous system back to a baseline state. This requires strict attention to biology, practicing pre-sleep hygiene, eating a balanced diet, reducing caffeine, and utilizing both aerobic exercise and targeted relaxation techniques. Group 2 focuses on operational interventions. Once physiology is stabilized, the clinician must reclaim control over clinical tasks and daily schedules. You execute this by honing time management. This looks like breaking projects into milestones, prioritizing to-do lists, and setting boundaries, including saying no to stress-inducing requests. Actively engineering your physical baseline and daily schedule builds a firewall against environmental chaos. Group 3 covers relational interventions. Even with structured time management, clinical work involves complex human dynamics, management conflicts, and emotional exhaustion. Mitigation requires proactive communication, expressing needs clearly to management, discussing difficult situations with trusted peers, and acknowledging when a workload is failing. Emotional outlets are also necessary. Journaling helps recognize stress patterns before they build up. Maintaining social connections outside work prevents your identity from being tied to the clinic. As this resource list highlights, robust professional support is available. Recognizing when self-management is insufficient and seeking professional counseling is a sign of professional strength. Finding the right mix of these strategies takes deliberate trial and error. Clinicians must monitor their own responses, just like adjusting a patient's treatment plan. Stress management is a continuous audit of professional environments and physical limits. Maintaining this oversight ensures the long-term clinical capability required for a career in physiotherapy.